Hi, I'm so glad to be here in the second round of MegaMind 2023. Thank you for having me. My name is Dr. John Koo, and today I'll be presenting on learning through complications. Benjamin Franklin once said, "Tell me and I forget. Teach me and I may remember. Involve me and I learn." In today's presentation, I would like to share what I learned from my case that had multiple complications. So let's get right into the case. Meet Cindy. She's a 57-year-old female with no significant medical condition present. Her chief complaint was that something was bothering her on her upper left quadrant when she was chewing. Her periodontal assessment was mild stage 1, grade A periodontitis with low risk. And number 14 had history of root canal treatment before, and a tooth was symptomatic to percussion. And her current diagnosis is symptomatic apical periodontitis. So after a discussion with the patient, we decided to extract the tooth and move forward with implant therapy. Here's a screenshot of the pre-op CBCT. We can see the need for sinus augmentation due to the low height of the alveolar ridge. And studying the sinus cavity here, there is a very wide base of the sinus floor and also very thin lateral wall present. In this situation, I prefer to perform sinus augmentation via lateral approach. It is also important to make sure the sinus membrane is elevated from the lateral wall all the way to the medial wall of the sinus floor. So let's see how I did. Tooth was removed by sectioning the roots to be minimally traumatic as possible. A replaceable bony lateral window was obtained using a piezoelectric surgical device. And PRF was inserted into the sinus cavity, and the remaining space after implant placement was filled with sticky bone. And we get a nice flap closure using PTFE and chromic gut sutures. Here's a screenshot of the immediate post-op CBCT. You can clearly see a nice dome shape of the graft material in the sinus without any perforation of the sinus membrane. And here I placed an implant Dentist SQ 5.0 by 10 millimeters. At 2 weeks follow-up, we can see the soft tissue healing looks phenomenal. And at this point, I'm happy with the results, for I did not know what was coming. Patient presents for her regular recall hygiene appointment. And now this is about 6 weeks since the implant surgery. And the hygienist, after her cleaning, comes to me and tells me that the implant seems to be moving. So I go into my room, I get my gloves on, take my Explorer, and do a little jiggle. And yeah, the implant is actually loose. The implant just spins right out, and there was soft tissue lining around that implant, which indicates fibrous encapsulation. In other words, 0% osseointegration. But the silver lining is there was no sign of sinus infection at this time. So there was a little bit of hope. So what did I do? On a second attempt, I carefully cleaned out the socket and placed in a wider diameter with a cover screw, trying to minimize micro movement. This is the immediate post-op image following the second attempt. And the implant that I used was Dentist SQ 6.0 by 10 millimeters. However, after about 3 days, I get a phone call from the patient. Patient is complaining of swelling, pressure under the eye, and foul smell coming out of her nose. So I prescribed a course of antibiotics and advised the patient to return after finishing the medications. So patient comes back after 2 weeks. She still has a lot of pressure in the eye. And as you can see, the left maxillary sinus is completely filled with fluid. So what do we do now? I remove the implants for the second time, but this time I also have to drain the sinus. This infected sinus is 100% filled with pus. So after mechanical debridement and drainage of the sinus for about an hour in the chair, another image was taken. You can see the sinus membrane is starting to come down a little bit, and as the air starts to fill towards the top of the maxillary sinus. But you can also see there's a huge hole that's forming after the implant removal and the graft material removal. Now, how do you manage this? And before we discuss how I actually manage this large hole, I want to point out something significant for you. What you also see here is hard, dense bone that formed along the lateral wall of the sinus, where initial bone grafting was done through the lateral window. I must credit sticky bone that was used for the sinus lift for this hard tissue formation, despite all this calamity. So going back to the managing the hole, I try to close it with sticky bone and PRF alone. Now, I've been talking about PRF the whole time, so let's go into that for a brief second here. Sticky bone is graft materials infused with autogenous concentrate growth factors. And the growth factors are coming from the platelets and leukocytes that are embedded into the mix, which increases the healing potential and is also known to have faster soft tissue healing as well. And the beauty of sticky bone really relies on the fibrin network that holds the graft together. So in this case, it will prevent the graft from falling out of the socket or even falling into the sinus. And with that, I was able to solve the complication here. Time passes, the patient returns after 6 months. And thankfully, there's no sign of hard or soft tissue deficiency here. The sinus looks clear, and there is nice hard tissue formation where I grafted following the sinus infection. You can also see the lateral window where I had grafted in the first attempt has thickened up quite a bit. So on this third attempt that I'm going to do, I won't be able to do another lateral approach. I have to stick with the vertical approach in this case. So here's a third attempt. Vertical sinus segmentation was done using densa burrs. And this time, a different implant system called Megagen's Blue Diamond 4.8 by 10 was placed. Using this implant with knife-edge thread design, implant insertion torque was recorded 70 Newton centimeters and ISQ value of 72. Also, notice the depth of the implant placement. It is not submerged subcrestally as deep as the first implant was. This will allow for better implant prosthetic design in the future. After 4 months, the ISQ value was 83, and a value that goes from 72 to 83 is an indication that the implant is ready for its final restoration. Also, on a side note, notice the adequate zone of attached keratinized tissue. You can really appreciate the soft tissue architecture around that implant. So the final implant scan was done using an implant scan body. And I delivered a custom titanium abutment with zirconia crown. And here I do want to point out some of the key factors for implant restorations. The 30-degree emergence angle and the gradual S-shaped emergence profile have been documented in numerous articles and papers in order for the restoration to have a good soft tissue health around the implant for the future. So in retrospect, what are some things that I would have done differently? What went wrong? I would like to share some of my reflections with you. In the first surgery, the extraction, sinus lift, and the implant placement went very, very smoothly. But why did it fail? It could have been because of low primary stability. Dentist SQ's implant design requires engaging into either apical bone or cortical bone. In this case, the implant was barely engaged on the cortical layer of the sinus floor, as you can see on the cross-sectional view. As shown in the graph, low primary stability might have affected the total stability of the implant, as the implant failed at 6 weeks. When the total stability was at its lowest, external forces being applied to that healing abutment would have caused a micromovement. According to this article published by a Canadian journal, lack of implant primary stability may not be considered a risk factor. In fact, over 96% of the implants with low primary stability survived as long as there was no micromovement. So in this case, based on the findings, if I were to go back in time and work with the same type of implant, I would place a cover screw and allow the implant with low primary stability to fully osseointegrate without the risk of micromovement from the healing abutment. On the other hand, if I have the same case today in my chair, I would choose to place an implant with better thread designs that allows for greater primary stability by engaging into the cancellous bone, not the cortical bone. And a good example would be Megagen's Any-Ridge or Blue Diamond. The main reason for this decision is because greater primary stability means less chance of micromovement of the implant. The second attempt that resulted in sinus infection is due to bacterial introduction into the sinus. But in my personal reflection, my overconfidence exacerbated the situation. Had I chosen to graft the site instead of placing another implant, the chance of sinus infection would have been low. Sinus is a very delicate space, and I should have respected biology and physiology more during the second attempt. Following the case, there are some lessons that I learned. Number one, primary stability and no micro movement is the key to success. It is such a fundamental concept, and this case reminded me to stay true to the basic principles. Number two, respect biology and physiology at all times, and don't be overconfident. Number three, autogenous concentrate growth vectors and sticky bone are always. We saw great examples on how sticky bone survived along the lateral wall despite the sinus infection, and how sticky bone repaired the large hole created as a result of the sinus infection. And number four, learn from my own failures and do not repeat the same mistakes. There's no better way to learn other than studying your own cases and failures, just like what Benjamin Franklin said. I hope this case shed some light for some of the listeners as it did for me. I'm so grateful to have a global community where we can share ideas, learn from each other, and grow together to become better clinicians. Once again, I want to thank Megamind for providing such platform for us to come together. Thank you for your time, and I hope to see you again soon.